Oh yeah, it's January 15th. So I'll take off the glasses. I don't need them right now, but hi. So it's halfway halfway over this month. So good. Thanks for joining us. Thanks for being with me today. We're going to talk about two interesting cases. Hope we have time for both of them because they both showed up this week. As a matter of fact, I'll be talking with one of those patients right as soon as we finish that webinar so that we can do a little Zoom conference together. It's interesting what happened. As a result of this pandemic, certainly teledentistry is in order, isn't it? You know, it's something we can do. It's something we can do via Zoom. If you haven't done a Zoom conference with the patient yet, do it. Do it. I mean, everything's on your screen. So the patient that we're seeing, that we are talking about today, the first patient is one who was in earlier this week, and then we had a doctor conference because we had all the doctors involved here, and you can have a doctor conference. We're working with a restorative dentist, and you can talk over the different variables, because in this case we needed to have a doctor conference in order to be able to come up with the different variables so I can present it to the patient. So then is, when can the patient come in? And we couldn't sync our schedules, you know, between her and her husband and our schedule and my schedule. You know, it was going to take a couple of weeks. Well, we don't need to do that. We'll do a Zoom conference, and that'll happen right after this. And then she and her husband come in and make the decision, because there are alternatives, there are treatment alternatives that we're going to discuss and that are going to be discussed at this particular visit. And so we'll handle that via teleconference, and they work. So you haven't tried it, you got to try it. You don't have to get the fancy lighting that I've got. Just use a webcam, and just use ordinary lighting. You've all done it, and just get used to that idea. It's a communication tool that will become and will remain very valuable. And you know, a year ago, nobody knew what Zoom was. Now everybody knows what Zoom is. So, and it isn't just Zoom. There are a number of different services you can use. GoToMeeting and all those different types of things. PPE, I want just a little bit about that. PPE is something that is important. We're emphasizing it more in our practice. You know, with the virus up, I know we're geared up for vaccines, and most people are waiting for their vaccines, or some have started to get their vaccines. But with the number of infections that are up, people are thinking about that more. And we've been questioned about that a couple of times as far as what we're doing. So it's important that you and your staff are all on the same page. Just make sure that all of the sequences and all of the materials that you've intended to use are actually being used. We went over that with the staff at a staff meeting this week, and make sure that everybody's prepared to discuss it, because it's something that's on a patient's mind. Yeah, I mean, our new patient flow is still, it's very, very good. And part of that may very well be the amount of communication we do about our PPE. So if you're not communicating, I know you're doing it, but if you're not communicating and telling a patient all the steps you're taking, you do it on video, or give them a piece of paper, or brief your staff, or all three of them, just do it. Just do it. Just do it. It will make a big difference. And of course, those patients in your office will pass that to their friends. So, you know, here's what my doctor is doing. It's a neat thing. And, you know, this is we're public relations is where we are. Scientific data is great, but public relations is what people listen to. So create your own positive PR. I think I covered everything that I want to talk about. Let's go to the. There's a couple things. No, I will. Let me go over that for a second. Yeah, let's go to the PowerPoint. Okay. Yeah, so we're going to talk about single missing tooth with a high smile line, which is of interest to all of us. And then acromegaly. So before we get into this, I want to thank, as always, the Oral Reconstruction Foundation for providing the continuing education credit. You've all been getting it. I know I haven't heard anything other than when I hear no complaints, it's good. By the way, if you want to give me some positive feedback, I just got a beautiful email today from this person was an IDS member, and it's motivating. It's nice. So if you're enjoying it, that's great. If you're enjoying it even more, hey, invite other people to take part in this. You know, there are a lot of people that that could take advantage of this. It doesn't have to be specialists. We're talking about treatment planning. So how do they go on? It's very simple. I just changed the website a couple weeks ago, so that's easy. Just go to directorofdentistry.com and just click on the free link. Please sign up for the free material, and you've got it. So anybody can go to this website and sign up for it. Preferably, it'll be a dental professional who's doing it, and just do it that way. Okay. So more people recommend, the more people will be doing what we hope is better treatment planning, which is, of course, the whole idea. So let's go to today's case. And by the way, if there are any questions or any counter arguments, which some people have today, I'm sure they will. Just use the Q&A box, and yeah, if you want to challenge me, you can challenge me. It's okay. This is, by the way, one of opinions. So I have my own personal feelings based on my experience, and other people would have other personal feelings based on their experiences, which is fine. Okay, so the intake call, patient is referred by her neighbor. So Nancy said she had periodontal work done by us. The patient has moved here from another state, and she, as usual, and we see this in Florida a lot. People spend a certain amount of time here and a certain amount of time up north, and so she wants to get her work done down here. So they're in Florida 7 months out of the year. Patient started treatment on the front tooth in that state, the state where she is, where she was, but would like to do the implant, the above of the crown here, since they're in Florida longer than elsewhere. Patient also started Invisalign with an orthodontist who gave her 20 sets of trays to get her through to the summer when they return up north for vacation. So she's in the middle of that treatment as well, which of course is a consideration when we're placing an implant. When's the right time to place the implant, if we're going to place an implant? Okay. So scheduled patient on 1/11 at 3 p.m. And these are all the notes that I get. This is what my assistant gives me when I'm making my new patient call, which many of you know that I do, but if you're new on the program, then yeah, I call every one of my patients prior to coming in for their visit. So patient sees Dr. X in that state. I'm supposed to take out Pennsylvania. Okay, she's in Pennsylvania. Along with her husband, who's scheduled for new patient exam as well. Okay, I called Dr. X, or my assistant called Dr. X's office, and they will send what they have by email. So you can all read that. So then I make the doctor call. She's in mid Invisalign on the lower arch. She had 2 accidents in her life. One was a pogo stick accident, so obviously that was when she was a kid, and that created lingual intrusion, which was corrected manually after the accident. And I put an S because she described other more recent accident where the same thing occurred. And Dr. X will be sending photos. Anything else that we want to go to here? Let me just see. Okay, so let's do it in this order. Okay, so here's my assistant's notes, and these are the notes before I get into the operatory. So patient needs full series of x-rays, CT, and pictures. The general dentist up north is so-and-so, and the surgeon did the extraction bone graft, and that's Dr. Y. The last cleaning, preventive maintenance visit was the beginning of December. Patient had the tooth extracted on August 5th, so August 5th, 2020. And bone graft was done. Patient's wearing a flipper to replace number 9. Patient leaves in July. She'll need to have more bone grafting done. Now, that's what I said. So let's eliminate that part of it. For now, patient fell in July and hit a rock, and that's why she finally had to have this tooth extracted. And she's also fallen off the back of a vehicle. So she's had multiple accidents, and multiple time there has been damage to these teeth. So let's go to the radiographs, okay? So there's nothing in the posterior to really look at. Let's, in the interest of time, let's just look at the radiograph of importance. So don't forget, these teeth were lingually intruded, at least retruded, intruded, not intruded, pushed lingually, at least twice in her lifetime. Does that concern you? Yeah, it concerns me a little bit. Not just that she may be accident prone, that isn't the idea, but what's happened to the anterior maxilla, the premaxilla as a result? I don't know. Do you? I don't. Okay. But you can see the evidence of the bone graft. This was done in August. And here the tooth was extracted and bone graft was placed. You can see what that was like. And I did find out from the surgeon that it was a socket fill, and he had placed a membrane, a non-resorbable membrane, between the gingiva and the bone on the facial aspect, which he pulled out a few weeks later. Okay. If you want to go through a few of the radiographs, let's go through the anterior a little bit. So you can see what's there. This is a large filling on the lingual. Okay. Apical, you might say there's a little bit of resorption there. Who knows? On number 8, and there's number 10. Okay, so that's what she looks like. Let's go to the photographs for a moment. And boy, are pictures important. So here she is. That's the retracted view, obviously, and you see the flipper in place. Okay. What do you notice? And just take a look, because you're going to be relating these observations to the patient as well. We're not just talking about treatment planning here, and I'm not the one who's going to talk about teach you how to do surgery. I did that for many years. That's not what we're here for. We're here for presentation. And so one of the things that we're recognizing is how prominent is the gingiva here? How prominent is the gingiva here? How prominent is the gingiva right here? And we'll look at that in a couple of different ways. So let's take a look at it with the flipper out. Okay, that's pretty good. You like that soft tissue? I like that soft tissue from a vertical perspective. Take a look. Here's the zenith here, but here's the zenith over here. That's a good sign. I like that. You do too, right? Good. All right, let's take a look at another view. Now, here's the smiling view. So now you can see that we see the gingiva here, right? Important to you? It's important to me. Anytime I do something in here, it's going to show. In the incisive papilla, it's particularly going to show. Let's see now. Accidentally, we got this view. I've got to say accidentally, but you may want to do this on purpose as well. Look at how she's not smiling, but she's raising up her lip. And so now you can see how much gingival display she has. Maybe she has even more than that. That makes a difference to me. Because if she has a lot of gingival display, no matter where this implant goes, it's how the implant is framed by the gingiva, or how the crown is framed by the gingiva, that's going to make a big difference to me. Let's take a look at a few more views. So here's the way our flipper is designed. Okay, flipper is designed with a ridge lap. You can see that right there. Okay. And there it is towards the front. Okay, little bit of pink acrylic at the apex. And here it is from the other side. So same thing. Okay, so it is a ridge lap. And the question then is, what kind of emergence profile are we really getting? Well, let's take a look at this view. you've already had a hint. Now, have I seen depressions a lot worse than this? So have you. But still, the gingiva is, it's lingual to the gingiva here and here. So at least from a gingival perspective and an emergence profile perspective, I'm concerned a little bit. Not as much as I would with other people, but don't forget it's high lip line. It's going to show. I'm a little bit concerned about the prominence of that gingiva, okay? And you can and should be too. I think that's all the views that I have here. So let's go to something else. All right, so let's go to the CT scan and just see what we've got there. Okay. So we'll look right through here. And now let's take a look at the bone that's in the anterior region. And if we look at the bone, if we look at the buccolingual width, what do we have here? 4 point what? What does that say? 4.69. Okay, somewhere between 4 and 5, right? What do we see here? Obviously, we see incisor canal, which is pretty big. Okay, now just so you can see this, I'm going to scroll back and forth a little bit. So let's scroll towards number 8. And now let's scroll over towards number 9. By the way, there's your bone graft. You see this a little bit more dense right there. You can see that. Now it gets a little bit narrower towards the middle. And now we get towards the distal, the incisor foramen goes away. We're closer to number 10. And we still got a little bit of the incisor foramen right there. You see that? Okay, it's got to at least enter into our thought process when we're deciding on the implant, how we'll place the implant, whether we're going to do a bone graft, what we're going to do. Correct? Okay. I think that's everything you're going to get out of that particular picture. And notice, for everybody's sake, notice that we're taking this view in occlusion. Okay, it's important that we take our CT scans in occlusion. We can learn so much, and I'll show you in the second case today why you learn so much just by putting this in occlusion. So I know they say separate the teeth. Don't separate the teeth. You can learn the occlusal relationship. It's going to make a greater difference in the amount of in how you're treatment planning, because you can see how teeth are touching. Okay, so it's, in my opinion, pretty important. Let's go to the Anatomage. Okay, so we've put a narrow implant in place. This is a BioHorizons 3.0 implant. And notice we've put that in there. We've placed it a little lingually so that we have some facial bone. Okay, and this, by the way, is after consultation with Dr. Furtado, our periodontist, and with my son, okay, who's a restorative dentist. And the two of them work together beautifully, and they create some really neat things. So I want you to go up and down, okay? So notice I'm going up and down. I'm using this little yellow line. I'm going up and down. Take a look. I'm up here. You can see, all right, there's kind of the crest of the ridge. I'll go even higher. You'll see it. It's well defined. There's the crest of the ridge right here at this level, about, let's say 12 millimeter implant, so 9 millimeters up. Roughly, the bone is really good. But let's take a look as we go closer to the coronal aspect. And notice, here's the cortex. Here's the cortex. But what's this right here? See, that's kind of muddy, and that isn't zoom. Okay, that's actually muddy. Okay, is that incisor foramen? Is that because the tooth was pushed lingually and the cortical plate went away? You know what the answer is? I don't know. I don't know. But I know that I want to have enough facial bone to put an implant in. And I also know that this is something here that may not be bone, okay? May not be bone. And by the way, that wasn't involved in the extraction. The extraction, as we saw, was facial to that. So the bone has already filled in the extraction side. At least I don't think the extraction was involved here. But this is a shadow here that we all should be looking at, because we've got to be able to predict in advance, or at least we have to be able to tell the patient in advance what we're seeing so we can describe it well to the patient. Okay, so Dr. Furtado went all the way and put the crown in so that we can see what that crown is going to look like and see how it's going to line up. And sure enough, it lines up pretty well. Okay. Now notice the position of the implant. Notice the position of the abutment in order to be able to utilize the bone where the implant is, and then the position of the crown. So we know there's going to be a little bit of a jog from a slightly posterior position of the implant to the crown. What does that mean? That means when the emergence profile is created by the abutment and by the crown, where's the tissue going to move? Yeah, it's going to move apically. And as we're creating this abutment, we want to at least mimic what the gingival tissue that's coming in from the other side. Well, that's quite a bit of pressure. Okay, that isn't the implant lining up with where the crown is. That's the implant lingual to where the crown is supposed to be. So we may say, hey, we put the implant in and that's fine, but what's going to happen to the soft tissue when we put that abutment and we put that crown in? We're certainly going to have to modify this area and make this concave, and there's nothing wrong with concavity. But it can't be too concave right here, because we've got to make sure that the cervical line of the crown is even with the cervical crown of what? The adjacent tooth or the adjacent veneer of number 8. Otherwise, it's going to look kind of silly because she has a high lip line. You with me? So remember, we're trying to make this not just easy for the patient, but also for the restorative dentist. Okay, and the restorative dentist looking at that, and this is part of your conversation. Here's where we are, and then we come up with the what-if scenarios, which are the same what-if scenarios that we're going to be talking about with a patient. I'm going to be talking about with a patient as soon as I get done with the seminar. What if the tissue goes up a little bit higher? What if the bone on the lingual isn't really present? What if? What if? See, because the soft tissue profile is making all the difference, isn't it? So that's what we're looking at. It's the soft tissue profile. And we got to look at that very carefully. It's the soft tissue profile on the facial, and then we're looking at the bone on the lingual. Now, if we were to do this procedure, okay, let's assume we're going to do the most conservative procedure. Well, no, let's go the other way. All right, so let's assume that we said, all right, we need more bone. We need more bone in the facial so that implant lines up correctly. So how are we going to do that? Okay, we're going to make an intracellular incision. Are you going to involve the papilla in that intracellular incision? Well, let's take a look. Let's take a look at that tissue for a moment. Okay, now that's rather thick tissue. Okay, and if we take a look at it from this perspective, okay, that isn't the thin case. Okay, it's a scallop case, but it's not the thin case. And therefore, our opportunities for loss of tissue are minimized, but they're not gone completely. And what do we do? Where are we going to make this incision in the papilla? We've got somebody who's a very, very advanced person who's taught us, who's on the line right now. You can take some surgical courses. Do we preserve the papilla? We make a horizontal incision here. Do we hide the incision and make it into the papilla here? I'll say not. Do we go right around the papilla? Okay, I'll say maybe. as long as we have some 6/0 proline suture that we can really suture well with, and then we make a beveled incision, maybe we do it that way. But as soon as I make that incision, as soon as you make that incision, I'm also either jeopardizing or enhancing the soft tissue profile that's already there. See what I mean? Okay, so yes, the crown will be a little bit more prominent, but it will move this tissue a little bit more apically. It will. And I love this soft tissue the way it is. But maybe not for an implant. So, how will we place the implant? We do the implant because I can tell you right now, if I'm going to do this procedure, I'm not going to do another bone graft. Because I'd have to do a bone graft both on the facial and the lingual, you know? And it's possible that we may even have, I'll show you a picture of it from Comish's book. It may be that we even have to enucleate the incisive canal in order to be able to graft that there. So I might have to graft both on the lingual to create the new profile in order to be able to create the new horizontal portion of the bone at the crest on the lingual aspect as well as the facial aspect. Do you want to do that? I don't. But the patient's in for an implant. Patient can have an implant. And I've got to be able to tell the patient the risk. And so the risk is going to go something like this. We're going to make a small incision, a stab incision, right at the crest of the ridge. So you can't see my mouse right here. So it's not going to include the papilla. It will just include the depressed portion of that area right there. Okay. And we're going to use a pilot drill using a surgical guide. It's the only way we can do this. I know I'm from the era we didn't use surgical guides. I'd use a surgical guide here. I think it's important. And I'm going to use a pilot drill at a fast enough speed just to perforate through the cortex and nothing more. I'm teaching surgery now. Okay, just be able to get through the cortex. And then I'm going to use that pilot drill as far as I need to in order to be able to get to the apical portion of that preparation. But I'm going to use very, 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 very slow speeds, 100 RPMs or less. Okay, I've got the surgical guide, which is going to keep this from the drill from shattering, and I'll be able to place that all the way to the apex in the exact position that I want, you know, with the surgical guide. But then the next step, again, preserving the soft tissue and not wanting to do anything to jeopardize the soft tissue in a patient with a high lip line case, I'm then going to use an expansion procedure. Okay, so we might use vertebras at very slow speeds to expand the bone. And what's the property of the vertebra? It also pushes bone in rather than the bone coming out. So we're adding bone. So as we're going slowly, we're expanding the bone, and we're also intruding bone, if you will, placing bone towards the apex in order to be able to create more bulk of bone, and then put the implant in. What else? With the soft tissue profile the way it is, I might take that stab incision, and I might tunnel out through that stab incision and put in and thread in a subepithelial connective tissue graft in order to build out that tissue to the face a little bit without doing a flap. I don't want to jeopardize those papillae without doing a flap. Does that require a little bit of patience? It sure does. Does it require small instruments? Yeah, it sure does. But essentially what we're going to do is to build that tissue, build in a little tunnel right under the facial gingiva in order to be able to create an opportunity for subepithelial connective tissue graft to make that just a little bit wider. And we'll do that using 2 coincident incisions if we can. From the palate, we fillet out the connective tissue underneath. Okay, so that's how we do it. But what's going to happen to the gingiva? I still can't guarantee where that gingival position is going to be. Now, if I were to do the big bone graft, and the bone graft, we got another 2 millimeters of bone in the facial, and we reconstruct the bone in the lingual, then I know everything's going to be okay. If the flap stays okay, some of us are very, very talented surgeons. Probably all of us are, but you've got to be super talented in order to be able to make this really, really work. Okay? And I'm sure we get somebody like Dave Matthews on the line here, or Peter Nordland. They would disagree with me. They'd say, hey, I got it. I can make this work. But I can tell you that if you've been I've been a member of a list for a number of years, what comes up all the time? It's I tried to graft here and we lost this papilla. Now what do we do? And it's a constant problem. So we're looking at risk mitigation here. What is the best shot for this patient? What do you think the best shot is for this patient? What do you think? Anybody want to get on the line and tell me what you think is the best shot for the patient? Anybody in the Q&A? Any guesses? All right. Then I'm going to tell you what my approach would be. Straight old fixed bridge work. Now I want you to see the number of things that can occur here. Right? So you've been staring at the case for a while. Let's assume we're successful putting an implant in. Let's assume the soft tissue is exactly where it's supposed to be. And now you're placing a single crown, okay, periodontist. I'm talking about periodontist from a restorative standpoint. Now you're placing a single crown in a good-looking woman that you want to match number 8. How closely can you match number 8? In terms of transmitted light value, because you have a veneer on number, or at least a crown, a ceramic crown on tooth number 8. How can you create the same transmitted light value in the same color on number 9? I can tell you almost always when we're replacing number 9, I'm saying we're going to have to do something with number 8 as well. In order to get them to match, I want to do the same thing on the adjacent tooth. Okay, otherwise they're not going to match precisely. Let's say the patient says, "All right, I got that. Let's see if we're going to if we do a single tooth. Let's see how we can make it match, and then if it doesn't match, then I'll redo the crown." Sometimes they'll say that to you, and you'll have to make that decision yourself. If the patient hasn't made the decision at the beginning, and then that crown doesn't match, whose fault is it? It's not the patient. You can't come back to the patient at that point and say, "Well, I told you." Well, it's written in the record. So we want to prepare that patient. And we want to tell that patient, if we're going to do number 9 with the implant, we're going to do number 8 as well. Okay? Periodontist, make it easier on your restorative dentist by telling the patient that. Okay? And if you do that, then the patient is prepared for what the bill might be. But if we take a look at a patient here who has 4 veneers in the front, who has had teeth that have been intruded, and I like the soft tissue where it is, boy, my first recommendation is a fixed bridge from number 8 through 10. I can see other people are arguing with me. That's fine. The first thing is, I want to minimize the amount of treatment that I'm going to give to this patient, and I want to maximize the cosmetic results. And she already likes the flipper. So if we do a fixed bridge number 8 through 10, and we do a build-up at number 8, and we do a build-up at number 10, and get used to that so that you can understand what the fee structure is, because your restorative dentist charges for build-ups and also charges for the crown for the fixed bridge itself. So if we're going to do build-up in 8 and build-up at number 10, and you do a fixed bridge number 8 through 10, what's the other thing you're going to do? You're going to do a new crown number 7. So number 7, 8, 9, and 10 are going to match. Okay? Now, if the patient insists on doing an implant, that's fine. I can say, here's what happens if we do the fixed bridge. Okay? And is there a risk of fracture tooth number 8? Of course. It's been intruded twice and has endo on it. Okay, so that's one risk. The risk on the other side is we've already discussed. We've got gingival risk, we've got bone risk, we've got the possibility that we'll do a preparation and find out there is insufficient bone in the lingual in order to be able to place that implant. Patient says, I still want to do the implant procedure because I like my veneers the way they are. Say fine. We'll do the implant procedure, but if we find out that there's no lingual plate or we're missing bone at the crest, when I do my pilot drill, we're going to abort the procedure right there. And then we go back to crown and bridge. Okay, so you're covering every option, covering every base. Does that make sense? Okay. And that's a discussion with the patient. That's the discussion I'm going to have with this patient at 1 o'clock today, 1 o'clock Eastern. Okay, so and we'll go through all of those, the entire scenario with the patient exactly this way. Because if you don't, and you make the decision to do this procedure, and we don't have full understanding of the risks, there's going to be a lot of discussion that you'll have afterwards if something fails. If something goes wrong, there's going to be a lot of discussion. So do your discussion in the beginning. It'll make a big difference. And just trace this and let the patient hear. Remember, we talked about storytelling in some of the previous sessions. Tell the story of what's going to occur and let the patient make a very, very informed decision. Yeah, it's going to take me about a half an hour, about the length of time it's taking me to talk to you right now, but it's going to be an important half hour to you. And will save you an hour, 2 hours, 3 hours, more surgery that needs to be done as a result of not having had the discussion at the beginning. Okay, so anyway, you got my opinion on that. Questions, any comments? All right, good. So let's go to the next case. Oh, maybe there's more on this or not. Okay, anyway. You can see overbite, overjet. By the way, the overbite was good. And 20%, that's a low risk procedure when we're doing a single implant. You know, a high risk procedure is if there's a deep overbite, but here there's no deep overbite. So that part's good. Okay, there's crossbite in one tooth. She has abfraction, a couple of teeth. She has a TMJ click on the left side. She has maximum opening of 57 millimeters, though. I mean, that's fantastic. Okay, gingiva is firm. Melonpathy is 4. Why do we do melonpathy? Because we may do sedation at some time. We want to know how patent the airway is. Besides that, you can say melonpathy score, and in 2 seconds, you've got a number, 1, 2, 3, or 4. It's more information. Here's the periodontal chart. Nothing of significant concern here. Oh, this goes to Mish's article. So in Mish's book in Contemporary Implant Dentistry, 2008, he talks about the fact that in the area of the anterior, you do and can enucleate an incisal foramen. So in this case, here's an incisal foramen that's in the way of placing an implant. The patient wants an implant. No prep's done on the other teeth. I don't know if it was a high lip line or a low lip line. It wasn't discussed here. But you enucleate this area. You graft it first. Some people enucleate this area, graft it, and put an implant in at the same time. Nothing wrong with that if you're comfortable doing it. The problem sometimes is the incisor foramen may not line up with where you want your implant. And so you might want the bone to harden up, to firm up first, which will take at least 4 months, probably 6 months, and then design the surgical guide and then put the implant in. Okay, a case like this, now you've got the flap reflected, you would probably do more bone grafting. You'd probably do some bone grafting in the facial and lingual here as well. But I hope this is a low lip line case. And notice there was an incision made right through the incisor papilla, wasn't there? Here's the thicker portion of it. I can't see the thinner portion of it here. And a vertical incision was made in order to get access. Okay. High lip line case, low lip line case. My guess is a low lip line case. Don't know. Don't know. All right, so let's talk about acromegaly. And acromegaly is a problem which occurs in the adult population, where you get a spurt and continually get a spurt of growth hormone, and you get changes in limb length, and in this case, mandibular length. And so the mandible grows as an adult. This occurred for this patient when she was in her 40s, 50s. Okay. So all of a sudden you get bone growth. So let's look at the radiographs for a second. Okay, this patient is referred from the orthodontist. The patient saw an orthodontist. And let's take a look at this particular tooth right here. Okay, take a look at that lower central. So this has a class 4 mobility. That's a class 3 mobility that's really, really mobile. And this has a class 2, almost a class 3 mobility. Is that root fracture? That root resorption? I don't know what it is, but I also know I can't save that tooth. Let's look further. She's not just biting on her front teeth because that's what she decided to do. This is her occlusion. And by the way, in our conversation on the phone, she said, I play the clarinet professionally. I can't do anything to screw around with my embouchure. Embouchure is the muscular method. It's the shape of the mouth as it surrounds the mouthpiece and the reed in a clarinet. That's called an embouchure. In fact, you also have a trumpet embouchure, position of the lips. For any of those, it needs to be firm. I can't change the position of the embouchure. But take a look. Look at what she's occluding on. She's occluding on tooth number 25, which is the loose as a goose tooth, and she's occluding on number 24, and she's occluding across number 7, 8, 9, and 10, and those are the only teeth that touch. Maybe 6 is touching number 27 a little bit. I don't know. Could be. That's all that's touching. Okay, now let's look at the CT scan, and now you know why it's so important to take the CT scan in occlusion. Look at the condylar position. Condylar position is just fine, isn't it? Okay, she isn't in protrusive position. Those condyles are in the exact position where they should be. And by the way, you know what the first question I asked her was? Is your bone growth stopped? You know, you've had this spurt of growth hormone. Is it stopped? She said, yeah, it took 6 years, but it's finally stopped. So we can't interfere too much during the middle of growth. We can't control this very well. Would you want to do orthognathic surgery in a case like this? You're darn right I would. Well, what's the patient saying? Hey, I got to play the clarinet. I'm not going to have orthognathic surgery. Besides, I'm too old. She's in her 50s. Okay, I'm too old to do that. Okay, do something for me. Help me. Help me. Now, she'd already seen the orthodontist, and the orthodontist is creating a retainer for her. It's interesting that the orthodontist is creating a retainer for her, and we'll see why in a moment. And by the way, we have not developed the entire treatment plan yet. We will. We're meeting with the orthodontist this week. But I saw her 2 days ago, and she's going in for major surgery next Tuesday. And she has a class 4 mobility on tooth number 25. And what's going to happen if she's intubated? What's going to happen with that tooth? And if she has and if that tooth comes out, which it could, I mean, say that's a good chance. I mean, the anesthesiologist does ask the patient, do you have any loose teeth? And then if the patient says yes, the anesthesiologist will be sure that in an oral intubation that the tube that's coming out of the mouth will be taped, in this case, to the left side of the mouth so that the tube is occluding with the non-mobile teeth. So the anesthesiologists know this, and they don't want to loosen teeth. But at the same time, what's the opportunity of this coming out in the next 2, 4 weeks, whatever it's going to take for this patient to recover from surgery? Pretty significant. Okay, so if she doesn't want to have a hole in her mouth, we've got to do something really, really soon. Okay, let's see if there are other pictures here that you can say. Yeah, so let's take a look at the relationship of the posterior teeth. And don't forget, we're taking our CT scan in occlusion. Okay, so you've got posterior right, and you take a look at the position of the posterior molar on the lower right versus the upper right, and on the lower left versus the lower left. How do you like the angulation? And by the way, if you take a look at the one on the lower left, you can see there's very little evidence of a lingual plate on the one on the lower left. And this is the first molar. Guess what? She has 7 millimeters recession on the lingual of that tooth. Tooth isn't loose, however. It's not. Okay, so that's what you've got to work with. And that's the way it is visually. Okay, now here's my concern. We're going to have to do something to minimize the stress. I'm going to show you what we're going to do in a moment, or at least I'll give you a suggestion as to what we're going to do. But what do I want to be sure of? I want to make sure that the patient feels that her tongue is comfortable because she has to play the clarinet. How can I easily duplicate an overlay partial denture, which I'll show you in a moment, to see how the patient feels about it? You know how I do it? Oh, by the way, okay, there's another view. Sorry. I do it in rope wax. Just take rope wax and I go along the lingual to simulate where a partial denture would go, and it goes across the occlusal. I'm putting in more bulk of wax than she's ever going to have with an overlay partial denture. I know some of you are asking what's an overlay partial denture. I'll show you that in a moment. And then I ask the patient, how do you feel about that? How does that feel to you? And now she can tell me. And what she told me was, it feels fine. It's not interfering with my articulation at all, which means it's not interfering with the tip of my tongue. By the way, you might ask, how did she play the, let me get out of here for a second. How did she play the clarinet? Do you know how she played the clarinet with that loose tooth? Because the mouthpiece will rest right on the teeth, or actually right on the lip, which goes over the teeth. She would put a piece of cardboard over her lower incisors and then put the mouthpiece in, and her lip would hold the cardboard in place, and the cardboard would protect those teeth from getting any looser. That's how she's playing. It's amazing how people can adapt, isn't it? So let's go back to the screen. I hope you're finding this interesting. Where was I? There we go. Okay, so we use rope wax. And by the way, I'll use rope wax a lot. I'll also put rope wax underneath the lip. If the patient says, you know, she wants to replace her upper teeth and her lip goes in, I'll place rope wax over the facial aspects of the upper incisors. I might go from 5 to 12 or something like that. Just putting rope wax in and thinning that rope wax out, and ask the patient whether she likes her lip support better, because then I can give a clue to the restorative dentist as to where the new incisal edge position needs to be. All done on rope wax. Rope wax you can mold. It's easy. It's quick. It gets soft with mouth temperatures. I love rope wax. You know, you can simulate things with rope wax. So this is an example. I don't think I ever used it for this before, but how often do you see a case like this? So there's an overlay partial denture. This is I got this off the internet by Dr. Julie Gillis, who I believe is in Colorado, if I'm not mistaken. That's an overlay partial denture. Now, do we know how we're going to be able to design an overlay partial denture? Because the idea is that we create an overlay partial denture, something that's removable, so that the patient is occluding on something in the posterior at the same time as she's occluding with something in the anterior. That's what you're preparing her for. And what we will do would be to scan upper and lower arches and look and go to the laboratory and work with the laboratory technician, because don't forget, those teeth are splayed way out. By the way, why are the teeth splayed way out? Let's look at that for a second. Nope. Let's go back for a second. That's the reason I had that picture. The teeth are splayed way out for a few reasons, but not the least of which is she has a huge tongue. There's something called a neutral zone. The teeth stay in the neutral zone. And what's the neutral zone determined by? It's determined by the muscular forces the muscular forces that are on the teeth. Okay, so you have a tongue that's providing more muscular forces than the buccal musculature is. The teeth are going to come out. When an orthodontist is working, the orthodontist is trying to work within the neutral zone. When we're designing dentures, we're trying to work within the neutral zone. And if the neutral zone, and if we're interfering with the neutral zone, if we're pushing something in orthodontically, it's going to interfere with the tongue. What do you think is going to happen? Well, we can put the patient in a retainer, but the retainer is fighting to keep the teeth in place because the neutral zone says the tongue is strong and the tongue is going to move the tissue out. In fact, she was told by a surgeon that she needs a tongue reduction, and she also said no to that. The orthodontist wants to see and is proposing that we might move those two teeth lingually, and we'll have to have that discussion with him next week as to what he's going to do about the neutral zone and how are we going to retain it, and are we going to retain it with a lower partial denture, and what do we gain from doing that? Are we going to get the teeth in occlusion? No, the only thing we're going to do is line up the lower teeth. So the lower teeth aren't leaning lingually, but they're straight up and down again. But that's to accomplish what? And we've got to have that discussion with the orthodontist. Okay. So if I were to look at it right now, what would I do? We've already extracted number 24 and 25. We did yesterday. And the orthodontist designed a retainer and put replacement teeth within the retainer. So it's a mandibular retainer, which is snapping in place, which, by the way, at least gives us an idea as how an overlay partial denture is going to work. And she's going to wear that for a while. And we see how her articulation is with that. And so you can play the clarinet with that. Well, that opens up the door to an overlay partial denture without doing orthodontic therapy. I'm not saying don't do orthodontic therapy. And I'm not saying that we shouldn't be doing orthodontic surgery. The patient is refusing to do so. Okay, so now we've got to come up with something prosthetically, which is going to be, which is going to work for the patient. Okay, so that's our second case. Are there any questions, any comments, anything you'd like to add to this? No. That being said, appreciate you joining us. If you enjoy these, let me know if there's something else that we can provide for you. Let me know. Just write to Lee at directorofdentistry.com. And if you think other people would benefit, just ask those people to go to directorofdentistry.com and they click on the link for the free stuff and they get on the list. Okay. I'll see you next week. Thanks. Bye-bye.